On today's episode of The Free Marketeers, we're talking about the first part of the report from Zondo Commission into State Capture and implications and links for the national health insurance, which is planned to be phased in steadily over the next few years. All of that right after this. Good afternoon, everyone. My name is Chris Hattingh. I'm a research associate at the Free Market Foundation, and I'm joined for today's episode by Mike Settas. Mike is the managing director at Sanagi and the chairman of the FMF's Health Policy Unit. Mike, how are you doing?
Yeah, good. Thanks very much for having me on, Chris.
Only a pleasure. I'm glad that we have an hour to pick your brain on all things state capture and NHI. Very easy topics. I'm sure you'll solve all these things for us in the next 5 minutes only. So listeners and viewers, make sure you take copious notes. For those of you who are joining us live, you will have an opportunity to ask questions to Mike later on. But first, we're just going to go through a few talking points and questions that I have for him, and then we'll get on to any input that you will have for us today. So, Mike, I thought we'd start off. I mean, obviously, the broader context here is state capture and part one of the Zondo Commission's report, which came out, was it earlier this month or last month? Things are already moving so quickly. So that'll be the broader context. But we're talking specifically with your expertise as well about the national health insurance. So I just wanted you to quickly just remind us what the NHI policy proposal entails and how you think it will affect citizens.
Yeah, Chris, I think to maybe just to start to look at it, it's quite an ideological proposal, in that it's quite cemented in socialist thinking, and in that vein, so the aspects of it which tell us that is that it calls for a monopoly on all healthcare in South Africa. It focuses on centralized control and planning around healthcare in this one entity that's going to be the NHI fund. And that's sort of kind of thinking with the thinking of the ruling party as their developmental state policy position. So it's very much a socialist ideology, the NHI, the principles of it. The actual practicalities of it, I mean, it is a very substantial change to both things. I'll try and cut it down into very broad nutshell, but the proposes very substantial changes to both the public and private sectors simultaneously. It's one of the concerns is to very substantial changes all over the place, and the difficulty in managing that and actually getting to the outcomes of what is intended from that. So that already is a concern. And we established this NHI fund, which will be, it's otherwise known as a single purchase of healthcare for all citizens in the country. And it will purchase healthcare from both private and public sector providers. And in getting the private sector in, what it's going to do is sort of sideline medical schemes, so their role will be substantially diminished legally through this bill. And that's always to force everybody into becoming members of this single purchaser, the NHI fund per se. So what that means is that citizens who currently on medical aid will be forced to use the NHI for the provision of certainly a substantial portion of their healthcare. And I think even equally so for private sector providers who would ordinarily rely on revenue from medical schemes for providing healthcare services to their members. They will now be forced to contract with the NHI because they're going to lose the revenue that they would have got out of medical schemes, because that role has been legally sidelined as such. In terms of the public sector, there's also very substantial changes there. So at the moment, the way in which public sector healthcare is provided is the public facilities, the hospitals, the clinics all receive budgets that come through from Treasury via the provincial equitable share, the conditional grants. And those allocations are made to each of those facilities on a predefined basis. And those funds are then used to run those facilities during the year. The way in which NHI is now going to change this is these facilities are not going to receive these automatic budgets anymore. They're now going to have contracts. Each facility is going to have to contract with the NHI. And in that process, then change from this model of receiving money through the budget process to getting money on a pay-as-you-provide basis. So a very, very substantial change in the revenue, the remuneration model of the public sector. And I think, if you can just sort of, and that's a very brief nutshell as to how I've explained it now, changing for the private and the public. But you can tell from what I'm saying, this is not a small incremental change, a little tweak here and there. These are massive sweeping changes to both sectors. And I think what's very concerning about it is that throughout the NHI policy process, which is now about 13 years old, it started in 2009, so it's been around a long time. There's been practically zero technical or feasibility analysis done in terms of some of these aspects. And then many more than what I've just mentioned, because obviously time-wise we couldn't go through everything. It's a very, very complex proposal. But there's been very little technical feasibility analysis. So it's very concerning. That's it in a nutshell, but I'll just emphasize how it will affect citizens. The concern is that government's making very large claims that it's going to be so much better than what we have. But they've done very little, if any, technical work to support those claims, to say that A, it will work, can it work, and I think the key issue is, can it be better than what we have? Why would we do it if it's not going to be better than what we have? And those are some of the concerns that I think citizens should be highlighted to citizens, because that will affect them. Thanks, Chris. Over to you.
Now, again, linking this back to the state capture point, and something that I've tried to illustrate and bring about quite often in some of my articles and arguments, is that the more you mix the state and the government with sectors of the economy, the more you raise the chances for corruption. I know that doesn't always happen. And of course, there's a lot of corruption that happens in the private sector itself, but just you increase the incentives. If you lower the economic freedom, the level of economic freedom, the only way for people to get ahead is by political contracts and tenders and that kind of thing. It sort of raises the stakes, as it were. So within that context, do you think, given the sort of setup, the proposed setup of the NHI, does it possibly increase the chances and opportunities for corruption in the future?
Yeah, I think very much so. I think there are two key elements to look at in this proposal. One is that there's the centralized NHI fund, this single purchaser. And you can kind of, from a layman's point of view, you can think about that as one giant medical scheme for the whole country, where every citizen in the country is going to be compelled to become a member of that medical scheme and get their healthcare there. So it's that centralization aspect of a very vast amount of money. If we look at what the white paper said in leading up to this proposal, although a technical costing analysis hasn't been done, and that's another failing of this policy process. The white papers did allude to some sense of a budget. And what they're looking at there is, in today's value, something around R500 billion annually that will flow through the NHI fund. So that's around 8.5%, maybe closer to 9% of South Africa's GDP. And that, for a developing economy to spend that amount on healthcare in the public sector is unprecedented. So it's the vast quantum of money that they're centralizing. And I think secondly is, in the bill itself, the governance structure is incredibly weak. It has no separation of powers. It concentrates power substantially. And I think those two components together, the centralization into a single entity and weak governance, I think it's going to be very appealing for the current patronage networks that exist for the advancement of cadre deployment. So I think there are extremely serious concerns, and I don't say this alone. I think many other observers have looked at this, and I think I cannot believe that this proposal actually sits in the context of where we are now as a country, facing the level of corruption that we've seen emerge out of the findings of the Zondo Commission. Over to you, Chris.
I think we all know that you'll decrease bureaucracy and corruption by adding more bureaucracy and corruption. I mean, it follows, of course, that sort of thing will work. But are there any recommendations or sort of not advice? Not that the Deputy Chief Justice Zondo, he can't sort of make regulations and laws, but anything that came out from part one of the Zondo Commission report, specifically regarding state-owned enterprises and state departments, he obviously made a bunch of recommendations and sort of revamping and processes, especially of SOE boards. I mean, how do you think this could affect the NHI bill? It's one, I think he is very highly respected. His insights carry a lot of weight. That doesn't mean that government officials are going to implement them, but theoretically, is anything that he pointed out that you think could affect the bill?
Yeah, I certainly think that his recommendations around how the boards of SOEs are appointed. I mean, I can't remember. I know it was right towards the end of the first report, which a lengthy 800-page read, but it was towards the end of that in which he said that it was absolutely imperative. I mean, he used I can't remember the exact words, but he used very, very strong words, to the extent that it absolutely cannot be left to the way it is. And so I think in a nutshell, the NHI bill would have to change that component. I mean, I'd like to see the whole thing scrapped, but, that's certainly that aspect to it. That is a very damaging aspect. And, if we look at what President Ramaphosa said when he gave testimony at the Zondo Commission, I can't remember if it was first or second time, but he described the manner in which the SOE boards were appointed as a massive system failure. Now, and then Zondo's obviously, come to the same conclusion, and with recommendations of a complete revamp of how SOEs are appointed. Now, if we look at this NHI bill, which admittedly was passed 2.5 years ago in 2019, it actually implements this massive system failure that President Ramaphosa referred to. I like the terminology, massive system failure. I think it was a good way of describing it. But if we look at the NHI bill, it absolutely entrenches this massive system failure. In the bill itself, it provides absolute authority and control of the entire NHI to the Minister of Health, virtually everything. The Minister can appoint the entire board, the CEO, the chair, the vice chair. I think there are 9 subcommittees in the NHI which control everything from what benefits are provided to the provider remuneration to provider accreditation, etc. And the Minister controls and appoints all people in those committees as well. So it's an incredibly weak governance framework, and it flies completely in the face of what Zondo has put forward as a recommendation to avert the results of those weak governance frameworks, and that is rampant corruption, cadre deployment, etc., etc. Thanks, Chris.
Is there anything specific in the NHI bill that to you indicates that officials will be able to play fast and loose with citizens' healthcare? I mean, there's obviously the case of the minister being given very wide discretionary powers, but I was wondering if there was anything else that sort of stood out in that regard. And again, it's not, I very much want people, if you're listening to this live or afterwards, sort of dissecting the conversation. It's not just about the current, maybe government. Obviously, a lot of our focus is there, but this will give any future Minister of Health and a bunch of bureaucrats and politicians this kind of arbitrary power over people's healthcare decisions. I mean, it's not just presume that your worst nightmare, worst enemy gets this sort of power over your healthcare and government and what they could do with it. What in the NHI bill to you stands out in that light?
Yeah, well, I mean, as you say, I think besides the sort of the weak governance framework that gives all this amount of power in terms of appointments, I mean, you're going to have to ask the question of who's going to get appointed. Right. People who are then compliant in terms of following whatever the minister or the ruling party wants to achieve in terms of running it. So it takes away a lot of choice it takes all choice away from members who would be accessing the healthcare through the NHI. I mean, the various subcommittees that exist will determine virtually everything, what the benefits package is, which hospitals, which doctors, which providers get contracted to provide services in which regions, and I think and the amount of remuneration that they will be paid. So you can see contesting between providers for these contracts, and no doubt will we see corruption happening in that process, and then what quality of care will be provided is, it would be like, for example, what we've seen in many cases with corrupt deals is that not only are the prices inflated, but the quality of what gets delivered is very poor as well. So very much, I think that risk exists in the way this NHI bill has been put together. It's weak across all of those things, and centralizing such control as well. Like determining what healthcare gets delivered in rural KwaZulu-Natal from some committee that sits in Pretoria somewhere in a building with 10 people around the table. It makes no sense. If we look at a good international example, Britain's NHS was born in 1948, and I think at the time it was right for what it was those years ago, and it was a very centralized system, very much like the NHI proposal is now. But Britain, over the years, had realized that the centralized control was not working, and by the time the 80s had come around, they decided to decentralize the NHS. Over the last 30 odd years, the NHS is no longer the centralized monolithic. It's in its name, but not in shape or form. It's completely decentralized in clinical decision making. It's even down to the aspect that members have choice over doctors, which district health authority they want to use, and because they came to the realization on their own that the centralization on such a massive scale, health outcomes suffered and accountability was also a problem in it. So I think the NHR is going completely against what international best practice has shown to work. I think but the potential to pay faster and less, I think, is very much there. Thanks, Chris.
Just on that note, are there any systems like this around the world that the NHI is sort of modeled on, or as you say, is it sort of modeled on an archaic view of healthcare sort of management as it was? Is anything close to what the NHI proposes to do? Maybe, I don't know, we seem to obviously still share a lot of affinity for Cuba and Venezuela, maybe.
I don't know about Venezuela having much these days, but no, but absolutely. I think the closest example you'll find of this NHI proposal internationally is Cuba. And I think we all know the love affair that the ruling party has with everything Cuban. In fact, there are only 5 countries in the world that have built an equivalent to what NHI is proposing. Now, if you think about it, that there are nearly 200 sovereign states in the world, and only 5 have gone down this road, and Cuba is the only developing economy that's gone down that road. So we would only be the second developing economy to do that. And there are obvious reasons to it, because it's a very expensive model. Cuba's public health expenditure is 11.5% of GDP. They've outlawed private health insurance, so you can't get, but just 11.5 is unprecedented in developing economies for public health spend. So it just shows you the inefficiency of centralized monopoly systems. So I think it's a great question that Cuba is the shining example of what not to do. And the NHR bill is exactly what Cuba is as a public health system now, as a national health system, in fact. Thanks, Chris.
Yeah, that portends well for the NHI's performance, I guess, for the future.
Yeah.
Just a bit about how the NHI would affect medical schemes, and effectively it outlaws medical schemes from being able to provide services in parallel with the NHI. So would this not amount to a denial of healthcare in terms of Section 27 of the Constitution?
Yeah, look, actually, I think that question's been posed quite a bit, and actually, the more I think about it, I think it contravenes Section 27, but not just for members of medical schemes. I think for members who are reliant on the public service as well. And I'll give you the reasoning.
Sorry, things like GEMS, and are you talking about that sort of thing?
No, I'm talking about the actual citizens who can't afford any medical aid and rely on the public sector.
Okay.
As a patient. Because Section 27 says that the state needs to implement any reasonable legislative and other measures. And I think the key word is to achieve the progressive realization of access to healthcare services. And I think that's that last bit. There's quite a key aspect. It doesn't direct that government must deliver healthcare. It just directs that government must create measures that achieve the progressive realization of access to healthcare. So whether that's private or public is irrelevant. If the government's achieving it, then they would be adhering to Section 27. Now, it's obviously very obvious that taking away the medical scheme cover is in contravention to Section 27, and I don't think it'd be much debate around that you are there. That is regressive. It's not progressive in what it's doing. But if we look at the argument as to why government wants to go down this road, why the ruling party is adamant on this process, is the policy process has constantly argued that the private sector is expensive, and that's why the public sector can't achieve anything better than what it's currently achieving. So therefore, it's justified in destroying the private sector. That's its justification. But I mean, I certainly don't buy it, because I can't see how public money and private money can conflate to affect one another in terms of its expenditure. So clearly with medical scheme members, Section 27, I think, is being contravened. Obviously, the legal people will be able to argue this much better than me. But if we look at the public sector, the aspect of what they're saying is like arguing that police struggle to fight crime because private citizens make use of private security services. I mean, it's a ludicrous argument. I mean, by having private security would alleviate the police in terms of fulfilling what the police would have to do if there was no private sector. And the same applies to health services. The more people rely on private healthcare, the less citizens have to rely on the limited resources that are available in the public sector, which means that the limited public sector resources are then divided out over less people. So that improves their access. So whereas NHR does the complete opposite, it takes that away. So I would actually argue that Section 7 has been contravened right across the entire country, everybody, not just the medical scheme members, but I think also in terms of citizens relying on public sector health services. Thanks, Chris.
In terms of the public sector specifically and its sort of performance, there are myriad examples, unfortunately, over the years, press coverage and investigations where we've seen government claims that these things happen, whether it's tragedies or just sort of lack of maintenance. I mean, the most recent example being Charlotte Maxeke Hospital in Gauteng, which I think it's now 9 months since the fire gutted it, and it's still not, a section of it at least, which is not operational and open again, and there's no indication of when it might happen again. So government's argument is the public sector is under-resourced. Is there any merit to that argument? I mean, from an objective point of view, and so, for example, if the Zondo Commission were to investigate the public sector, would we see a similar picture to what's coming out now in the report from Zondo?
Yeah, okay, so, I mean, is there any merit in the issue of resource? So I think what's important to look at, and I just say, last year we produced a research paper on just identifying the health assets that South Africa has in both public and private. It was the one part of the research paper, and then the other part was following the NHR policy process and to the claims that they made in that policy process. And I think it was important from a point of view that there is this constant mantra from government about the public sector being under-resourced, both financially and in medical personnel. And that's the reason for its inefficiencies or its insufficiencies at this point in time. But in actual fact, if from the research we looked at, is the public sector is not as under-resourced as to the extent that government claims it is. I mean, obviously we have a problem overall with having enough doctors in South Africa and sufficient resources to that extent. But to give an example, the findings that we had was look over roughly the last 2 decades, both in financial and human resources, the public health sector improved substantially. And the two main areas are obviously financial budgets, allocations, and medical personnel. If we look at medical personnel, for example, this was a study undertaken by Treasury amongst other public health departments. The number of medical personnel working for the state, not posts advertised, etc., actual full working posts, went from about 140,000 medical personnel in 2006 to 200,000 in 2016. So in the space of a decade, there was a 42% increase in the number of personnel working for the state in the public sector. If we look at the public health budgets, which is a very simple exercise. In real terms, so measuring it against taking out the effect of inflation and the effect of the growing population, the per capita health budget in real terms in 2020 was double what it was in 2000. So that's a very, very substantial improvement in public health allocation over that 2-decade period. Now, we haven't seen a concomitant improvement in health outcomes over that period. In fact, in many areas, we've probably gone backwards on that. So the concern, so you asked me the question, do I agree with that? And I think obviously I've answered that question, but no, I don't. But the real concern is that the NHI health policy has been predicated on this lack of resources, which is simply not true. The NHI, the large part of the drive of the NHI is saying that give us more money, that big pot of R500 billion annually, and we'll give the whole country very good healthcare. But the public sector's already had a lot more health, a lot more money, a lot more doctors, and things haven't got better. So they're actually already contradicting themselves in terms of what they're claiming they will be able to do. So I think that answered that the first part of the question. Do you agree with that? And obviously, I think we can safely say that I don't. Your other side of it was if Zondo did do an investigation on the public sector, what would we find? And I think it would probably be just more of the same as to what his current findings are. And although the Zondo Commission didn't specifically investigate the public health sector, I think there are a few things that we could look at to get a sense of it. The most obvious and most public one, obviously, was the Digital Vibes contract, which in reality quite a small contract in the bigger picture of billions of state capture, but nonetheless, a very high profile. The previous Minister of Health who was involved, he obviously stepped aside because of the amount of outrage around it. We can look at things like the PPE procurement scandals from almost 2 years ago, where the SAU is investigating thousands of contracts, which they've already concluded, I think 2 days ago, that all sorts of adverse findings in those amounting to billions and billions of rands. I think probably one of the most horrific examples is the very public assassination of Babita Diakoran, who was a whistleblower in the department. Clearly, she must have been uncovering some very substantial funds for whoever is perpetrating what she's investigating to have gone to such extreme lengths of assassinating them. So I think a lot of things like that we could look at, and I think that probably the most specific one would probably be something out of the Office of Health Standards Compliance. Now, this is not actually a very well-known office, but it's an office that exists in the Department of Health. From a layman's point of view, we can probably think of it as a sort of clinical auditor general. They do audits on the public health system. Every 4 years, they'll rotate to have completely covered the entire public health system. And they then put out their audit reports on their findings. It's unfortunately not a Chapter 9 institution, so it does serve at the pleasure of the Minister of Health. So they could be removed if they started covering too much. But fortunately, they are still going. They have run for quite a few years now, and their audits come out with 13 broad categories of findings, ranging from clinical skills to outcomes to cleanliness, sort of staff attitudes. But the two lowest scores out of those 13 lie in governance and operational management skills. Now, the office requires a score of 80% or more in order to meet their minimum health standards, the compliance aspect, if you like. Now, in governance, they scored 22% on average across the entire public health system, and in operational management skills, they scored 35%. Those are the two lowest scores across their 13 categories. Now, if we go to look at Zondo and we say, what were the Commission's findings? I think in an absolute nutshell, you can break it down to that. Governance broken down, that failed in various aspects, and then a lack of appropriate skills within the various positions needed to run those departments properly. In essence, the practice of cadre deployment. And I think those are the two, to my mind, those are the two essential components of the Zondo findings, were broken down governance findings and the practice of cadre deployment, which meant unskilled people placed into positions, because of loyalty rather than because of skill. So on your second part of your question, I think yes, I think that the findings would be pretty much the same. Thanks, Chris.
Oh, maybe if he sticks around for another 200 years, he'll have time to investigate healthcare as well. But and along with everything else, there's so much in this country. Unfortunately, I believe the cover story of this week's Financial Mail asked the question, why isn't President Ramaphosa really winning, the fight against corruption, which is the war against corruption, which is interesting. And a few more cynical commentators have said, well, to win a war on anything, you actually need to have a problem with that something and have an issue with it. And I wonder whether there's some truth to that, and how embedded, unfortunately, many in the ruling part of the ANC are just, they can't sort of move out of these habits, which have been established now for years and months.
Unfortunately, yes. There was a fantastic article on Politics Web, I think 3 days ago, by R.W. Johnson, on the history of the ANC and how the cohesion and the requirement of a very disciplined, cohesive being. It's just such a long history of the ANC that it's not going to be able to break itself up to fix itself now, to put the country first, if you like. But anyway, I digress.
No. Moving back to the NHI, I just wanted to give you a chance to highlight how we compare to other countries. So again, that argument by government of, we compare so poorly against, we spend so little on public health, and that's why it performs so poorly. Just wanted to ask you how we compare to sort of other, I guess we'd call them middle income countries. I don't think we are part of the OECD, but we're not sort of the top echelons, obviously, but just how you think we compare to sort of peer countries in terms of healthcare spend. This can be overall, or you can do the sort of public-private breakdown, I guess.
Yeah. No, well, I think quite easily the research paper that we did last year actually touched on this aspect. So we are still a middle-income country. We are sort of starting to head down and may well fall out of it at some stage, but we certainly have been there for a long time. I mean, when we look at how we compare in terms of two aspects with peer countries, public health expenditure and clinical outcomes, we don't compare well, unfortunately. Certainly in terms of the findings that we came to. What we did we did quite a specific exercise in. We took South Africa's per capita GDP, and then we took 24 countries that were immediately higher than South Africa's per capita GDP. So all countries we compared to all had per capita GDPs higher than South Africa. So we were comparing against richer peer countries. And the very top country out of the 25 countries was the per capita GDP was roughly double what South Africa's was. So we had that sort of spread of GDPs. Then when we looked at our public health expenditure, we ranked 10th highest out of the 25 countries. So even though we're the poorest country on a per capita GDP basis, our public health per capita expenditure was the 10th highest out of the 25 countries. So it meant we actually spent comparatively well compared to these richer peer countries. But when we looked at health outcomes, we looked at 5-year mortality rates and infants, one-year mortality, we ranked almost last. I think we were third last in the one and second last in the other category. So in essence, citizens aren't really getting value for money in terms of the amount of money, taxpayer money that's being spent in the public health sector. But I suppose maybe a bit cynical, but it's not really out of line with many of the other areas in which many critics also argue that our expenditures are not out of line, but our outcomes are. Example, education. I think, Chris, it doesn't look good when we compare to many of the other countries, unfortunately. Thanks.
And just on that last point, do you think, even if you don't have any sort of hard insights into this, but do you think the last 2 years of lockdowns and just the main focus on COVID, would this have changed anything at all in terms of that healthcare spend? Do you think it's going to radically sort of patterns have shifted? I mean, obviously people, especially in the first year in South Africa of lockdown, they don't have a choice. They couldn't go to their doctors, for example. But what does your gut tell you how COVID might now have shaped healthcare spend?
Look, I think there are two sides. I mean, I know the private sector actually financially did very, very well out of it, because all the sort of elective surgical procedures or many of them were delayed or done away with. So, I mean, a lot of medical schemes have, for example, delayed their increases because they had built up such massive reserves. But conversely, that meant a lot of private sector practitioners didn't earn money in that stage. So for them, it wasn't great. It would have been very bad. For the public sector, I think in principle, like, everything should have stayed the same. But I think the economic damage that COVID's done means that the future budget allocations to health specifically, I think, are going to come under pressure. We already saw it last February with the budget speech. There were quite a few cuts in the health space. I think in terms of some of the on the HIV program, there were some cuts to that. I can't remember a few others. I know there was some certainly some concern around those. So I think the public health budget, along with many other public budgets, are going to come under pressure because of our macroeconomic position, which has obviously been largely affected by COVID. Yeah.
Yeah, I don't necessarily see that sort of macroeconomic position strengthening. If we get more than 2% growth, I think this year, that would be quite an achievement. But it is from a low base. So let's see what we get in the February budget. It's almost, I mean, it's end of January now, so we don't have to wait too long to hear sort of the state of the country's budget at this point.
Yeah, but I think the key issue is that unless a lot of these policy principles are either fundamentally changed or realigned, we're not going to see an improvement we're not going to see growth. Let's put it that way. Very, very limited growth. So a lot of those structural issues just need to be changed. I think they've been well discussed already in the public domain. So, yeah, thanks.
Before we get into the final question from my side, I just wanted to ask you, this idea has been floating around a lot. I don't know if it can be applied strictly to healthcare, but maybe in some ways it can. Obviously, you'll know better than I will. But the idea of state proofing. So we're now talking about the state failing to provide a lot of services, and communities and individuals trying to sort of take care of themselves now, doing a lot of normal services that the state should be providing for themselves. Last year with the July riots, we had communities taking security and protection sort of into their own hands. A very stark, unfortunate but necessary example of what happens when the state sort of starts to fail its obligations. Do you have any sort of advice or insights for people who are interested in state proofing their healthcare? Is that at all possible? I mean, if the NHI obviously happens, then it'd be more difficult than not. And part of the argument also against the NHI is that for more well-off people, they can simply head overseas to get their healthcare. But for the majority of South Africans who are already under a lot of pressure, inflation is increasing, they're going to be forced to go to ever declining state and public facilities. So what do you think of that idea of state proofing one's healthcare?
Yeah, look, I think conceptually people doing it with things like electricity by going off the grid, or getting boreholes, or private education. But if the state does succeed in this NHI proposal and removing the ability to purchase private care, I think it's going to be very difficult to state-proof yourself. It's not, citizens can't be self-sufficient in providing their own healthcare, because they need professionals to deliver it, and those professionals need to be paid. And as you said, it's only going to be the very wealthy who will be able to go overseas and fly healthcare there, which will be a very small percentage of the population. So I think more importantly, I think if I was to say what should the average citizen be doing, is to say, make sure this policy proposal doesn't materialize. Let's fight this thing tooth and nail, because we have a world-class private sector that can, with the right regulatory framework, which it needs, could expand substantially, and that would give wider access to more citizens. And as I mentioned earlier, an expanding private sector would actually be better for everybody, including the public sector patients who rely on public sector healthcare.
Okay. So moving on to our final question for today, unless anyone puts anything forward in the comments. So we still have Mike for another 5 to 10 minutes if you have specific questions for him. Just Mike, from my side, is there, or what is the alternative to fixing healthcare in South Africa? So we've got the well-documented poor performance from the public sector. The private sector is unfortunately becoming ever more expensive. How is there a balance? And if so, how do we get right? I mean, we just said don't give the Minister of Health all these powers, but if we made you Minister of Health and possibly Tsar of the Treasury, how would you fix healthcare in South Africa?
I think no thanks on the public appointment, though. It's not my scene. Yeah, I think we can probably broadly split that into private and public and say how can we see them working together, but also in their own right they each need quite a lot of fixing. I think the issue relies on what is policy at the moment, and policy unfortunately still stands as this NHR bill that's there. It is, as I mentioned, I think a bit earlier, it's 13 years old. It became official policy in 2009. We had to also look at where the ANC was in 2009. In April, they won the national elections with just shy of 66% of the national vote. So they were in a very strong position. A policy like this didn't really, if there were critics, it didn't really concern them too much because of the extent of, the electoral support that they had. But I think that a lot has changed now, and I think ultimately this policy process needs a rethink. Whether the ruling party has the ability to go through that kind of reform to change, I'm not sure, but I'll give you what I think would happen. I mean, given we've seen what Zondo's outlined in the commission, I mean, it's been shocking, and it's going to proliferate under NHR if it carries on like it is, because we saw about the weak governance model, the centralization of vast amounts of money, so we know that will carry on. I think COVID demonstrated how the public and private sector can work together well in terms of meeting a very specific healthcare need. And I think if we look at NHR's massive tax bill, the tax tag, the price tag on it that requires substantially increased taxes, I think to the extent of something like an additional 3% of GDP from what we currently have, and the fragile economy we have, it's just not going to happen. So I think carrying on with NHR is a waste of time and money, because it can't actually come about, because it simply doesn't have the money that government is requiring for this policy process to be passed through. So I think to go back to each sector and look at how we can do that, I think it's about improving efficiencies to get more out of the same level of resources that we have. In the public sector, the obvious thing, and I think this applies to many departments, is the mismanagement, the fraud, the poor governance that is the Achilles heel of the public health department, which we can witness in the medical malpractice liability, which is now sitting at 120 billion rand, a number, which is an astronomical figure, given that that's half the total annual public health budget for this last financial year. But it's a reflection of the inefficiencies of the health system, and it's costing a lot of money, which is drawing away resources that could otherwise expense. Unless we fix this problem, the public health sector is just going to decline continually. So that it needs to be reversed. We need to get the right people into those posts. We need to get the fraud. Obviously, I mean, I speak ideologically here, but we need to get all that stuff out. Otherwise, the public health sector is just going to decline to where it is. On the private sector, though, and I think a positive is that we've got the health market inquiry, which was a very intensive, in-depth, evidence-based 6-year study by the Competition Commission on what the problems are in the private sector. So actually, we don't even need to do any planning there. We could literally just take that, uplift it, and say, let's do it. But it requires the political will to get that done, and I'm not sure that's there. But that is a blueprint that I think could work. And if that does work, we expand the private sector. And as I've said now, probably more than once, that an expanding private sector is good for everybody. We see it in countries like Brazil, who, I think if I remember, Brazil's per capita GDP is something like 3 times South Africa's, although it's still a developing economy, but they're much wealthier than we are. And they have more money to spend on healthcare than we do. Their health spend is per capita much higher than us. But they still provide tax incentives for private sector players to come in, whether it's providers or insurers, to actually expand the private sector, because they have a good understanding of what an expanding private sector does for absolutely everybody, not only the people in it, but the people who then rely on the public sector the limited resources in the public sector. So I think it would be nice to see our government switch to this more progressive policy thinking rather than these very grandiose and ideologically driven NHR type systems, which have massive potential for failure because they're such broad, wide, sweeping changes to everything. So yeah, I think a change in thinking would really bring about necessary reforms. Whether that'll happen or not, I don't know. But anyway, thanks, Chris. I have time, so if there are questions, I'm not restrained. So.
Yeah, that's part of the sort of advocacy work that we try to do is change we obviously suggest policy proposals and ideas, but also just changing the sort of thinking around the role of the state and people's participation in society and how we can try and sort of push things in a more free and, we argue, prosperous direction. We do have a question about the Zondo report specifically. So you now have to don your sort of predicting cap, as it were, and tell us whether you think any real prosecutions will come out of the Zondo report.
Yeah. Like, I'm a contradiction of a cynical optimist. So my cynicism tells me that I don't think so, but I'm optimistic that let's put it this way: I don't think it will come from the current government. Well, as long as they remain in power, I don't think it will happen. I think the ANC is too. It's too interwoven into its current structures. It's tied together with the patronage networks that it's built over years. And to disassemble it, it'll be in the same position that F.W. Clark was in the early 90s. He knew that to make the changes, he knew it would be the destruction of the National Party. And he went ahead and did it, and rightly so. But I don't think the ANC's got that. I don't think it has enough of its moral compass left anymore to say to itself, okay, we need to reform, we need to change. So to answer your question, in the current form, I don't think so. Maybe if by some miracle we have a coalition government after 2024, maybe, I don't know. Let's see.
Yeah, I think we should look at the next sort of 2 to 3 years. We've got the upcoming ANC conference at the end of this year that can tell us a bit about where the party is going internally. At least we've already got movements now with people vying for power positions, with putting out op-eds in the media and that kind of thing. So
it's going to be a circus this year. That's all we can be certain of.
Oh, may you live in interesting times. We can't complain about that at all.
There we go.
But Mike, yeah, I think we will wrap up there. Thanks for your time today. It's been really good getting your analysis of the NHI and Zondo. So thanks for joining us.
No, thanks very much for having me on. Thanks to the guests and listeners, etc. And yeah, much appreciated. Take care. Thanks very much.
To those of you who joined us live today, thank you very much. As always, we greatly appreciate your support. Before you leave, if you haven't yet, please like the video, comment afterwards, make some suggestions and leave your ideas. And also, if you haven't yet subscribed to our channel, we greatly appreciate your support. Please look forward to more episodes in coming weeks and months. Until next time, take care out there and we'll chat soon. Bye-bye.